We will be talking about the application of nursing process, specifically the assessment of your gastrointestinal. Talk about assessment. For us to perform a comprehensive assessment for our patients, regardless of the system being involved, two parts are being included. One, health assessment or interview to deal with subjective data, and then we have physical assessment to gather the objective data. This slide differentiates the signs of nutritional status for good nutrition and poor nutrition. Allow me to focus on some items. Generally, a patient with good nutrition would appear to be psychologically stable, whereas a patient with poor nutrition has the tendency to become withdrawn and apathetic. That simply means that the nutrition also affects the psychological status of our patient. EC fatigability is usually caused by anemia. Okay, and anemia may be caused by the lack of a specific type of vitamin B or because of the lack of protein, which is your hemoglobin. Also, the patient has a tendency to become irritable if there is poor nutrition. On the other hand, in the integumentary system, it would appear to have good skin turgor if it is good nutrition. The hair may be shiny, lustrous, and then there is minimal loss. So take note that even if the nutrition is good, minimal loss of hair is considered to be normal. On the other hand, the patient may appear to be dull, pasty, scaly, and dry related to the lack of fluids, or the patient may have bruises due to the lack of clotting factors. So remember, your clotting factors is also processed or derived by the liver from the macronutrients that we are taking. So if the patient would have problems related to the clotting factors, multiple lesions may also appear. The health of the hair is also dependent to the protein intake of your patient. So if the patient is having poor nutrition, brittle hair may be expected. Then, head, eyes, ears, nose, and throat. So in good nutrition, it would appear bright, oral mucous membrane would appear moist, the gums would become pink, tongue would become pink, which would be indication of adequate nutrition. If your patient is having poor nutrition, the tendency is eyes appear dull, the conjunctiva is pale related to anemia, there may be discoloration under the eyes. The oral mucous membrane is pale, the gums become red and spongy, and then it would bleed easily, also related to your clotting factors again. Then the tongue, which would appear to be red and swollen, may be related to your pernicious anemia. Then abdomen. Okay, the abdomen would appear flat and firm in somebody who has good nutrition. Whereas flaccid abdomen and distended abdomen may indicate undernutrition and overnutrition, respectively. Musculoskeletal system. Remember, even though our problem is gastrointestinal system, if our patient would have problems with absorption, for example, if calcium is not properly absorbed in the small intestine, our patient would have flaccid muscles, wasted appearance, and then skeletal malformations. Okay, because your products, which are vital for the functioning of your muscles and bones, are also absorbed through your small intestine. Neuro. Imagine if your neurologic system is already impaired because of poor nutrition, the patient would appear to be inattentive, easily distractible, okay, or easily distracted. Impaired thought process. Patient may have paresthesia and reflexes may become diminished. Remember, especially when we're talking about vitamin B, your vitamin B acts on the nerves. So if there is a problem or deficiency on vitamin B, paresthesia is more likely to occur. Okay? Try to define what is paresthesia. Next, on the assessment of the gastrointestinal system, we would want to know about the subjective data and then the objective data. So, in the biographical or demographic data, one consideration that we can have is your gerontologic considerations among our patients who are old. These patients would appear to have difficulty swallowing and chewing. They would have heartburn and reflux. They would have problems with malabsorption. And then they would have constipation. Now, try to pause this video and review table 43.3 in your textbook and try to find out what are the anatomical and physiologic changes among old adults that leads to difficulty of swallowing, chewing, and these other signs and symptoms that they may experience. Now, pain. Among the most common symptoms that our patient may experience is pain. So when we are dealing with pain or any other signs and symptoms, your cold spa will be there. Character, onset, location, duration, severity, precipitating factors, and aggravating factors. So you need to find out these factors. Now, common to a patient with gastrointestinal problem is what we refer to as referred pain. meaning it is a pain experience which is not directly related to the location of the primary site of injury or inflammation. One particular example is cholecystitis. If your patient is having cholecystitis, meaning inflammation of our gallbladder, if you can recall, your gallbladder is located on your right upper quadrant. Okay, your patient will also be able to feel pain on the shoulder. You call this one referred pain. Okay, pain felt on the other side of the body other than the one where the inflammation or infection or the problem occurs. Okay, this is brought about by the same nerve endings or brought about by the same nerve branches that supplies these two different parts of the body. In other words, class, the nerve that goes to the upper part of the shoulder is also of the same branch to the nerve that goes to the upper quadrant of the abdomen, specifically in your gallbladder. That's why your patient would have pain on the shoulder if ever your patient is having problems with the gallbladder. So kindly try to take note. Pause the video and try to take note the common sites for referred pain. Okay, especially for cholecystitis, pancreatitis, and then your appendicitis. Also try to take note the site for renal colic. Other signs and symptoms or common symptoms that the patient may complain of. One is dyspepsia. When I say dyspepsia, this commonly refers to your indigestion. Okay, etiology. Dyspepsia is a common concern among our patients who have eaten a heavy meal. And then those patients who have consumed fatty food. It is more common among patients who consume fatty food than the patient who consume carbohydrates and protein. What do you think is the reason? Why is it common among patients who consumed fatty food? Next, intestinal gas. Your intestinal gas may manifest as belching if it goes out of your mouth, and then flatulence if it goes out of your anus. So belching usually would involve deposits of air on the upper GI tract, whereas flatulence would involve on the lower GI tract. Patient would complain with bloating. During palpation, you might feel distension, and then sometimes they would say feeling full of gas, and then their tendency is to burp. This may be brought about by acid production. This may also be brought about by formation of gas due to intake of gas-forming food. Now, try to ask yourselves, what are examples of gas-forming food? This may also be caused by the decreased motility of your small intestine and large intestine. Next, nausea and vomiting. So your nausea and vomiting, when your patient would vomit, it may be containing undigested particles, especially if your patient had dyspepsia, especially if your patient have bowel obstruction. So if your patient has bowel obstruction, instead of the materials or digestive materials to go down of the gastrointestinal tract, the tendency for it is to pile up before the obstruction, and then later on there will be a reflux of your digestive contents. Next, blood. Okay, presence of blood in your vomitus would be referred to as hematemesis. And then you have your bile and gastric juices also. So if there is increased production of acid, if there is bile obstruction, okay, or if there is increased, production of bile, okay, and then there will be obstruction on the lower gastrointestinal tract, the tendency is for your patient to vomit your bile and gastric juices. So these bile and gastric juices, when it will appear on your vomitus, would be sour to the patient and then has the tendency to appear greenish, yellowish. Okay, etiology. It may be caused by infection, peritoneal irritation, if you have peritonitis for that matter, then mechanical obstruction as I have mentioned, then central nervous system problems. Try to find out what are the central nervous system problems that may cause nausea and vomiting. Then you have radiation, okay, radiation which is used for the management of your cancer, and then distension of your upper intestines. These problems can all lead on to, nausea and vomiting. Then, change in bowel habits and stool characteristics. We need to find out if our patient is experiencing constipation or diarrhea. If our patient is experiencing constipation, it will be about time to ask about the fiber intake of our patient. If our patient is having diarrhea, we need to ask about the presence of pain, whether it is cramping, and then we need to check for the concurrence of nausea and vomiting. diarrhea with nausea and vomiting would be an indication of acute gastroenteritis. Okay, highly, there will be an indication of infection. Then, we also need to check for melena and hematochezia. So class, when I talk about melena, remember this refers to your black tarry stools. It is an indication of upper gastrointestinal bleeding. Okay, so usually the bleeding would come from the stomach, and then once it passes through the small intestine and then the large intestine, the tendency is for it to appear already to be black tarry. Hematochezia. When I talk about hematochezia, this is the presence of bright red blood, okay, in your stools, or streaks of blood in your stools. So hematochezia is an indication of lower gastrointestinal tract bleeding. Then you have greasy stools and acolic stools. Greasy stools would indicate that there is presence of fats in your stools. That would mean that the fat is not properly metabolized or not properly absorbed by your GI system. It may also be caused by increased or too much intake of your fats. Then we have your acolic stools. Acolic stools class is also an indication of the lack of bile, because the color of our stools is taken care of by your bile. So the lack of color on our stools, if the stool would appear to be gray colored, that would signify biliary obstruction or biliary duct obstruction, meaning the bile which comes from your gallbladder is not able to go through the duodenum. Okay, remember the entrance site of your bile, okay, from the liver to the gallbladder, from the gallbladder to the small intestine will be on your bile duct going towards the duodenum. Then other symptoms, you need to check for the change of appetite, okay, because that would signify also overnutrition or undernutrition, weight gain or loss, and then dysphagia. Dysphagia is a common concern among patients with esophageal cancer. Okay, so if your patient is having esophageal cancer or structural problems in the esophagus, okay, dysphagia is a common sign and symptom. Then, we also ask for the present and current illness. We ask for known GI disorders, possible genetic or environmental causes, then chronic diseases, medications, allergies, and habits by the patient. We also ask the family history, commonly the history of cancer because of its familial predisposition. Then we also ask for the social history and dietary history. The intake of carcinogens, again, would lead to cancer. And then for the objective data, we start with the vital signs. Okay, remember that if our patient would have anemia, the tendency is for the blood pressure, for example, to be decreased in the long run. Then general nutritional state, body build. We check if the patient is endomorph, mesomorph, and then ectomorph. We check if the fat is evenly distributed throughout the body. We also assess the oral cavity for the presence of lesions. We also ask our patient to swallow to determine if there are any discomfort during the process of swallowing. Then, let's remember that the nutritional status of an individual has consequences. It is a powerful determinant of health and well-being. However, and also as a healthcare professional, remember that this is a modifiable factor. Okay, meaning we can do something about the nutrition of the patient. Malnutrition may increase the risk of infection and chronic diseases. So for example, undernutrition is usually related to increased infection, decrease in physical and mental development, especially if we're talking about pediatric patients. Overnutrition, on the other hand, leads to obesity, and then commonly it leads to metabolic syndrome. Metabolic syndrome would entail an increase of your cholesterol, okay, near normal or above normal of your blood sugar. And then your type 2 diabetes. Remember, your type 2 diabetes is considered to be lifestyle related compared to your type 1 diabetes, which is a high hereditary component. Then, so these are the three body types that I've mentioned. So you have your ectomorph, your mesomorph, and then your endomorph. People can have an optimal nutritional status, or they can be under, over, and or malnourished. So take note, class, that morbid obesity is also considered to be a form of malnutrition. So when I talk about malnutrition, it does not mean only underweight. It could also mean overweight for that matter. Then in physical examination, notice that the order, instead of inspection, palpation, percussion, auscultation, when we are dealing with the gastrointestinal system, specifically the assessment of the abdomen, okay, the order would be inspection, auscultation, percussion, and palpation. Now, What is the reason why this is the order of assessment? Okay, try to answer that question. Then, when we are assessing, we watch out, we look for the lips color, moisture, swelling, cracks, and lesions. Okay, cracks or lesions may indicate dehydration, may also indicate abnormal growth in the oral cavity. Teeth, we check if it's complete in children at 20, in adults at 32. We check for the presence of dental caries, which would indicate poor dental hygiene, loose teeth, which would indicate probably lack of calcium or unhealthy gingival tissues, and then the absence of teeth, which all lead to impaired chewing. Next, gums. We assess the color of the gums. We assess for redness. We assess for swelling, bleeding, and pain. Okay, swelling, bleeding, and pain would be an indication of gingivitis. So class gingivitis is inflammation of your gums. Okay, it may be also infection of your gums. Then mucosa. We expect mucosa to be colored light pink. However, if there is presence of white patches, we suspect the candidiasis or your oral thrush, a fungal infection. Then, if there is white patches plus red patches, we would suspect malignant growth for that matter. We also assess the color of the tongue, its mobility, and symmetry. We also check for the presence of ulcerations and nodules or lesions. Class ulcerations in the tongue usually lead to impaired or imbalanced nutrition less than body requirements because this will be very painful on the part of the patient. We also check the pharynx and observe the uvula, the part that rises when we say ah. Okay, we check the soft palate, the tonsils, and then the posterior pharynx. And watch out for signs of inflammation. Okay, which may appear as redness, edema, and ulcerations, which are thick and yellowish secretions. So these are signs of inflammation and infection. Abdomen. We check the abdomen for tenderness and organ enlargement. However, remember during the assessment, we do inspection first leading to auscultation prior to assessment of palpation and percussion. So remember, okay, tenderness is assessed through palpation, and palpation is supposed to be done last when we are talking about abdominal irritation. Then we also check for masses, spasms, or rigidity of the abdominal muscles, and the presence of fluid or air in the abdominal cavity. So, try to remember the 4 quadrants and then the 9 regions of the abdomen. Try to familiarize the organs that belong to each of these quadrants. So please pause the video and review the organs in each of these quadrant and regions. Then, assessment of the rectum. Although not common in our culture to assess the rectum, but a comprehensive assessment would entail inclusion of which. Okay, so rectum, that would involve assessment of the perineal skin and the perianal skin. Okay, class, the perineum is a common site for irritation among your patients. Then we assess for the presence of pruritus, which may indicate infection, assess for the presence of fissures, and then external hemorrhoids. So class, there are two kinds of hemorrhoids. So you have your external hemorrhoids and then your internal hemorrhoids. Okay, of course, as the term implies, external outside, so that will be readily available during inspection. Then you also check for rectal prolapse. Class, rectal prolapse would appear to be like this one. So in rectal prolapse, this would be the appearance of the normal rectum on the left side. However, class, on the right side, you would see that the rectum, okay, and then the anal structures here went out. Okay, so that will be very painful on the part of the patient. Other than pain, class, your main nursing problem would be necrosis, because this part that went out, okay, would have impaired blood flow due to the compression of your anal cavity here. Okay, so if this part would compress your anus, class, and then part of your rectum, it would lead to impaired blood flow and later on necrosis. So this part needs to be reduced. When I say, class, reduce or reduction, that would be pushing that part, okay, which is commonly done by the doctor, pushing the part, class, and to be returned to its normal location. Okay, you call that one reduction. Then, digital rectum examination, or your DRE. So, when I say DRE, class, take note that you should be using your gloves. If your patient is not actively bleeding, the use of clean gloves is allowed, because your gastrointestinal tract, specifically your rectal and your anal area, is considered to be not sterile. However, if your patient is bleeding, you need to use sterile gloves for the purpose that it may go towards the system of your patient. Okay, the bleed there may be a possible access for the bacteria to go to the system of your patient. So to prevent sepsis, you should use sterile gloves if there is active bleeding. Now, you instruct the client to bear down so that it will not be irritating on the part of the patient, and so that you will not be feeling resistance when you will be inserting your finger. Then, you note for the sphincter tone. When I say sphincter tone, you would want to note the internal and external sphincter of the rectum. If it can put pressure to your finger, that would mean that the tone of the sphincter is good. Then you check for nodules or irregularities on the anal ring. Class, on the picture, you can see that the examiner is trying to assess for the prostate. Okay, so that is the location of your prostate for your men or for your male clients. Okay, the next lecture will be talking about physical examination and diagnostic test. Thank you very much for your attention on this lecture.